Thank you, Pal sir, for giving me this opportunity. So the topic is stop prone positioning for PCNL. Supine is the way. I say no, prone PCNL is going to stay. So friends, lot of theory has been discussed. So I am not going to, elaborate on anything. But just one study I am going to show, because all the studies between supine and prone, there is only one good meta-analysis which is present. Why that study is the best? Because, so they have chosen the best studies, 9 studies, 6 were up to the mark, only 3 studies were non-randomized, and 6,000 patients between prone and supine, and this is the inference. Hospital stay, no statistical difference. Operative stay, slightly shorter in supine, but it doesn't really matter in our setup. I really don't know, because most of us work in private nursing homes. So even if it takes half an hour more, we are not bothered. Complication rate almost the same. But the most important thing is the stone-free rate. All stone surgeries, only one point is important, that is we should have the best stone-free rate. And this study shows in prone, the stone-free rate is significantly higher as compared to supine position. The discussion ends here. Okay, so there is no confusion that prone PCNL gives best stone-free rates. Okay, right? After this, saying all this, we'll come to the practical points of supine position. Okay, now positioning. Have you seen this? First they came up with supine position, then they said this is not good, we'll do some bards, flank free. Okay, then came original Valdivia, then came the modified Valdivia, okay, and then came the Galdakevo modified Valdivia. I'm not able to pronounce also, they're so confusing names, okay. So they are using n number of positions, they are not happy, okay. And my friend is saying that you have to learn supine position. Just listen to this, what he is saying.
To do PCNL in an absolute supine position.
Listen again.
So supine per se is not a supine position as such. Supine is an idea where you don't have to reposition patient again and again position. So before that, one should understand it is practically not very feasible to do PCNL in an absolute supine position.
He is only confused what
so
position he is going to
per
do.
se is not a supine
it is
position
his video, I am not quoting any other
is
video.
An idea where you don't have
just
to
listen to
reposition
what he is
patient
saying.
again
Are you
and again
understanding?
position.
Supine, it is
So
not supine, but
for
supine
that,
is more
one
supine.
should
What,
understand
I mean, what is
it
this?
is practically not very feasible to do PCNL in an absolute supine position.
It's not
So supine per se is not a supine position.
Supine per se is not supine. So what is
supine
it?
is an idea where you don't have to reposition patient again and again.
So friends, this surgeon has now devised his own position. Some mnemonic, fancy mnemonic, he has given Fosmal or something like that. If you see the position, it is almost like this, 90 degree. I am afraid while operating, even if he just pushes the patient, the patient will become prone. You know, you see his videos, he is keeping the patient 90 degree. So after 5 years, he will be showing, he will be demonstrating in conferences, and he will be showing prone PCNL. But he will label it as supine, because supine is not supine. He is only saying it. Okay, right? So it is like Kama Sutra position. No one is happy with any position. That's why so many positions have come in Kama Sutra. So it is like supine position. Okay? So I say that position in supine positions is like Kama Sutra position. We'll be very practical. I'm not going to show anything. We just go to the next step. Position is given, right? Okay? Then comes the procedure. Only thing they'll do is mark this line, posterior axillary line. The other friend, Sandeep, he also impressed on this posterior axillary line. Don't go above the posterior axillary. 100 times they'll repeat this. So this is like a Lakshman Rekha. If you go above, you are going to create complications. Okay? So don't touch the posterior axillary line. You have to be below the posterior axillary line. What will happen? Suppose you are near the posterior axillary line and you go beyond it, you are gone. Like this fellow. Okay? Touch the posterior axillary line, you are gone. So, my dear friends, So you are not worried. See, you are not worried about the pelvic access system, the type of stone, the location of stone, hardness of stone. You are only worried about the posterior axillary line. That's all. So you are not bothered about the anatomy of the, nothing you are bothered. You are just concentrating on one line, posterior axillary line. Okay? Is it feasible? And they say that you are not learning supine PCLS. Very simple. Prone position, lot of space is there. In supine position, there is only one small square where you have to keep on making fancy attempts to puncture that calyx, and sometimes it is so difficult. Again, clinically, if you want to do a superior calyxal puncture, it is very extremely difficult to puncture the medial superior calyx, and most of the times you require it, as seen in this slide, which is I have borrowed from Dr. S.K. Pal. See how beautifully from above you come down for the upper calyxal puncture is not possible with a supine PCNL. So they say that you operate in sitting position and you are comfortable. Is it so? No, it is not. Every time the monitor is not in front of you. Okay? Second thing is the monitor always should be at the eye level. It is not possible. In TRP, you can raise the chair, you can raise the table. In supine, it is not possible because you sit like this, the table will go up. Okay? Third thing, you have to frequently tilt your head. Try doing supine, you will come to know how difficult it is. You will have neck problems. You will have back problems, back strains. So it is not easy to operate. It is not a one position like in TRP that you are sitting right in front of the patient. It is not like that in supine position. Okay? So practical points, right? Then irrigation. Have you seen them operating? Everything comes out because of gravity, and they'll keep on shouting, pani, pani, lagao, puncture, ye, wo, press, do this, do that, lot of irrigation, and still they are not happy because everything comes out because of gravity. They are filling up the fluid from below. The fluid is coming out from the irrigation, from the ampullate sheath, and this is ultimately the end result. See this. The anesthetist is fed up. The OT staff is fed up. Everyone else is fed up in the OT. What procedure is this? Horrible. Who's enjoying? Just see. Only the surgeons are enjoying. But they have chosen the procedure. One is saying, other is dancing. I mean, what is all this? And the sisters are whispering, "Sar ka dig gaya, sar ka dig gaya." See, practical points. You do a supine position, you will be like this at the end of the procedure. So let us compare ultimately what exactly it is. Space for puncture, very wide in prone, less in supine. Upper calyxal, very easy, very difficult. The tract length is short, the tract length is long in supine. Dilation is very easy in prone. Kidney keeps on moving in the front in supine, very difficult to dilate. Nephroscope mobility, everyone has told, they've shown the slides, excellent in prone, restricted in supine. Distension of the collecting system, very nice in good and good in prone, very difficult in supine. Injury to the surrounding organs, mainly more injuries when you are doing an upper calyxal supine puncture, okay? And stone fragments can wash out probably slightly faster, but this is debatable. We can put a forceps in prone and just extract the stone very fast. Anesthesia, high risk, but who's worried about the anesthetist? I really don't know. You have to worry about your own stone-free rates and not the comfort of the anesthetist, though my wife is an anesthetist. And combined retrograde axis, not possible, but I don't know, it's debatable. And X-ray exposure, maybe because of exposure to the hand might be more in prone, but more greens with prone and more reds with supine. Okay, so my dear friends, who will deny that prone is the best position? Thank you.